Perfect.
Very good.
All right, awesome. Okay, hi everyone. I'm Cherry, and good morning / afternoon. So today I would like to share with you my research project I have completed with Alex, who's my supervisor in the program. This research project applies machine learning within the emergency clinical setting to proactively address the emergency department ED overcrowding problem. So today, I kind of would like to break down my research project into four areas. Firstly, we will sort of talk about the research background motivation, covering both the clinical problem as well as the machine learning concept. Second, we'll kind of focus on the methods and particularly the data and how I handled the data for the project. And I'll briefly then present the research results. And I will sort of want to close with an outlook perspective as we move forward from this research. So first of all, research background and motivation. And to provide some definition, ED overcrowding, defined by the Canadian Association of Emergency Physicians, is a situation where the demand for emergency services exceeds the ability of an ED to provide quality care within appropriate timeframes. So this problem is a worldwide concern. So in Canada, the total number of emergency department visits had almost tripled in the last 10 years, while ED length of stay over the last 5 years have been increasing every year by an average of 6%. So in 2019, 1 in 10 admitted patients will stay in the ED for more than 36 hours. Similarly, in the United States, more than 90% of EDs regularly experience emergency department overcrowding, while in China, more than half of the patients stay longer than 6 hours in the ED. So ED overcrowding is really a multifaceted systemic problem, and you can see that by this sort of conceptual model here. It increases healthcare costs, decreases emergency response, results in occupational stress. It also negatively impacts patient satisfaction and patient quality of care through medical errors, poor clinical decision-making, fragmented care delivery. The causes of ED overcrowding are composed of various input components, such as patient volume and acuity, throughput components such as staffing levels, ED processes, and ED capacity, and output components such as inpatient bed capacity. In fact, access block, which is defined as the inability to transfer admitted ED patients to an inpatient unit, is the primary cause of ED overcrowding. And this blockage prevents new ED patients to access care efficiently. So patients who received poor care or found to return to the ED, as well as emergency staff who are burned out, will have a higher turnover rate, both of which will further exacerbate the problem in a vicious cycle. So here we can see that this overcrowding problem actually extends beyond the boundary of the emergency department. So let's flip over and talk about machine learning. So statistical learning theory, or SLT, constructs the theoretical foundation of the currently popular concept machine learning. So this theory studies from examples of independent X and dependent Y variables and produce a function or predictive model. If we input a new value of X into this predictive model, it can predict a new value of Y, or also known as the Y hat or predicted Y. This predicted Y is then compared with the true Y value using a loss function to evaluate the model's performance and fine-tune the model parameters. So this process reflects the idea of a machine that learns from examples with a flexible and adaptive learning algorithm rather than a fixed one with a prescribed set of parameters, hence the term machine learning. So the origin of SLT is dated back in the late 1800s with the concept of regression, which was quickly developed into linear regression, LR, to predict continuous dependent variables in a linear fashion. In the 1900s, the nonlinear logistic regression was developed to mark the beginning of classification, and more complex models such as neural networks were developed as computers improved their processing powers. So just to provide maybe like a brief overview of the different neural network models that are utilized in the study, we have here neural network, or NN. It models the all or none firing behavior between nets of neurons by learning from examples and fine-tuning the parameters of the model to determine the firing behavior of these neurons. And then we have This is called the recurrent neural network, or RNN, which builds on this concept, but rather than learning each input variable as a separate entity, it learns the relationships between the sequential input variables, or the temporal attributes, via a recurrent structure consisting of internal memory of the previous input. However, RNN can't learn over long sequences of inputs, as the new internal memory overwrites the existing one and a vanishing gradient problem occurs, which diminishes effective fine-tuning of the parameter. Long short-term memory, or LSTM RNN, is a type of RNN that can minimize the impact of the vanishing gradient problem and selectively keep existing memory, and it's a superior method with higher prediction accuracy. So LSTM has been applied in the healthcare sector. When we're talking about RNN, and particularly the use of LSTM, we're looking to utilize sequences of data or data that change over time. So some examples here in healthcare include patient clinical trajectory with sequences of patient admission events to forecast interventions, next diagnosis, future readmission risk, or even early sepsis detection. We could also have electrocardiogram, so ECG classification, and seizure prediction, both of which use sequence of electrical signals recorded from the body. And there's also influenza forecasting using an infection rate observed over time. So in sort of my literature review for the project, machine learning has been applied to address the ED overcrowding problem. And some examples here include hospital admission prediction using patient triage presentation, ED length of stay prediction for fast track patients, and for patients with exacerbations of chronic respiratory illnesses, as well as ED wait time prediction. And this is where my research will be focused on. And these examples sort of utilized summarized waiting times, number of patients in the waiting room, or triage presentations. So we can see here that these examples don't utilize data that illustrates a holistic sequence of patient events within a patient hospital journey. So based on the literature review, the SLT has been applied to address the ED overcrowding problem, but the method used do not explore the temporal relationships within the patient journey, even though we know that patients receive care across a continuum of events with one affecting the next. So as we saw in the previous slide, most of the ED wait time prediction research don't use sequences of patient events, so the temporal relationships between events are not captured or utilized. The prediction of ED wait time serves as a clinical decision support tool to proactively address this problem, the overcrowding problem. And despite many hospitals publicly displaying ED wait times, the information is often inaccurate and misleading. While studies applied SLT to predict ED wait time, no studies was found to use LSTM RN method. The data sets used also do not explore the entire patient hospital journey, despite that the overcrowding problem, as we saw, extends beyond the emergency department. So due to these research and practical gaps, this project aimed to construct ED wait time prediction models using LSTM RNN and compares prediction accuracy with non-LSTM models. So, and really to answer the question, does a model using LSTM method perform significantly better than the non-LSTM ones in ED wait time prediction? So now I'm going to go a little bit into the research method. And so these are the steps that were taken in the project. So in sort of an overall perspective, we collected the data, cleaned the data, visualized the data, and pre-processed the data. And then we kind of constructed some models to train, validate, and test with the data. Here, we have used two types of loss functions, mean absolute error, MAE, and mean square error, MSE. And finally, we evaluated the model performances using a one-tailed two-sample t-test. And my focus in the next few slides will really on steps 1 to 4, which is mainly on the data part. So first of all, the collection of the data. So through ethical approval, we collected an 8-year data set from a hospital, which contained patient timestamps from patient arrival to discharge and various clinical data with about 600 1,000 patient records. This data set is recorded in their electronic health record system in the hospital, as well as through annual reports as well. There were no personal identifiable information within the data set. So the table here shows the timestamp data and the clinical data elements. So the patient timestamp data collected represents the patient hospital journey as they first of all arrive to the ED, get triaged, get registered, get seen by the physician, and if they're well, they can go home, or if they're not well, they will be admitted to the hospital, and so on and forth. The clinical data on the other side includes CTAS level. This stands for the Canadian Triage Acuity Scale, which is a 1 to 5 scale that ranks the acuity of the patients as they come into the ED. So CTAS 1 is the most acute and 5 is like the least acute. And we also have other pieces of data like admission service, and as well as hospital service bed capacity. So in terms of the data quality, we found that the data set contained about 15% of missing data and 5% of chronological error. So for things like patient is being assessed by the physician before they get registered, and also about sort of less than 1% of unreasonable data, we call it. So this is sort of looking for like prolonged length of time between different timestamps. So an example of this would be, we found that it was taking 56 days between registration and initial physician assessment. So that was definitely quite unreasonable. So we had to remove it. So in the end, we removed these poor quality records, leaving about 400,000 in the data set for us to still kind of use. So with that data set, we kind of started to look at what it looks like in terms of visualization. So in next few slides, I just want to show you some of the visualization graphs that I have done in order for me to understand the data set. So this is a graph for the CTAS distribution, and we can see that CTAS 3 patients are the most common and 1 and 5 are the least common. This graph here is the bed capacity over the 8 years. So it's interesting that we see that medicine beds have the greatest increase over the years, while the other types of beds seems to be quite stable. And this graph shows the monthly ED visits over the 8 years. Interestingly, we see that there is a dip in the visits during the month of February, and really this could simply due to the fact that there are fewer days in February. And despite that influenza season during the fall, we do see November having sort of a dip in visits, which was I found was quite interesting. So this table shows the average, median, and standard deviation, or the spread of ED wait times and length of stay of the different category of patients. We see that ED wait time for admitted and non-admitted patients are quite similar. Sorry, here 1.5, 1.6 in hours, and but the waiting time across different CTAS levels are quite different. For example, you have 3, 4s, and 5s. Their median hovers over 1 hour, while 1 and 2s are under 1 hour. And lastly, these two graphs show the relationship of ED wait time and the time between different timestamps. So the one on the left looks at the time between arrival and triage, while the one on the right looks at the time between registration and physician initial assessment. So we can see that the relationship, which is measured by the Pearson and Spearman correlation here, is more positive for the second graph, meaning that ED wait time is more positively correlated with the wait between registration and physician initial assessment, as opposed to the wait between arrival and triage. So after visualizing the data, there are still lots of work to be done. So we calculate some additional variables, and some examples are sort of the projected ED wait time and annual ED waiting room capacity. We also wanted, so in order to capture the delays between each consecutive patient timestamp throughout the patient hospital journey, the differences between each of the patient timestamp were taken to form a sequence of timestamp differences. So I will talk a little bit more about this in next slide. But in the end, we randomize the data and we scale it and so that is usable to be processed in the model. So there were 2 experiments that were conducted in this research. The first experiment used a single patient sequence to predict the average ED wait time in the next 2 hours. So there were 3 categories of independent variables that are used. Firstly is the timestamp difference sequence, which is constructed by taking the differences of the consecutive timestamps shown in the workflow diagram on the right, forming a sequence of 5 timestamp differences. So we have here the time between arrival and triage registration, and so on and forth, and we take the differences of these and to form a sort of a 5-unit sequence, and this is called the timestamp difference sequence. Secondly, we have clinical data, which includes admission services, their admission status, hospital ED capacities and CTAS level, and calendar data, which includes the elements of the patient arrival timestamp. So for experiment 1, it examined 3 different types of LSTM models as shown on the top here. We have here LSTM RNN, which contains a single layer of LSTM. LSTM RNN3, which contains 3 layers of LSTM, and hybrid LSTM-NN, which attaches a neural network to the single layer LSTM RNN model. We also did test the non-LSTM models, which are shown on the bottom, and it includes simple NN model on the left and the linear regression or LR model on the right. So the models that are highlighted in red used all 3 categories of independent variables, while the other 2 models utilized only the timestamp difference sequence. For experiment 2, it used a multi-patient sequence of 11 consecutive patients. So rather than just using 1, now we're using 11 patient sequences to predict CTAS-specific median ED wait times in the next 4 hours. So for each of the 5 CTAS levels. So here the output is a little different, where it spits out 5 values rather than 1. And each of these 5 values represent the median ED wait time for a specific CTAS level in the next 4 hours. So since not all CTAS levels of patients will be present to the ED within that 4-hour period that we're trying to predict, especially for the more rare CTAS 5 and CTAS 1 and 5 levels, a weighted resampling method was performed to minimize the unbalanced distribution of these values. So sort of to summarize, this is the null and alternative hypotheses for the experiment. So using a 1-tailed 2-sample t-test, a significance level of p-value less than 0.01 is used to determine the rejection of the null hypotheses here. So in experiment 1, we compare the loss values of the best performing LSTM with the best performing LR, as well as the best performing simple NN. And then in experiment 2, we compare the best performing LSTM and LR models across each of the 5 CTAS levels. So I kind of want to highlight a bit about Python and the project challenges here. So for this project, I've used Python programming language, and I really liked it. And some benefits with Python is that you can actually use a application called Jupyter Notebook to really organize your codes, and that really helped me sort of laying out each step and having it really nicely laid out for me. And this application can be installed and it's accessible on our own personal computers. So that was also another great bonus for me. And the other thing about, a good thing about using Python is that there are so many like available, highly usable, useful libraries that are in the Python programming language. So some examples I have listed here, these are the libraries that I've used for my project, and the graphs that you guys just saw are done using this library, matplotlib. So it was really useful, and most of these libraries contain many documented resources and to help guide you in terms of understanding the function of the code and actually using it. There are also some limitations with using Python, and these limitations mainly stem from sort of the limitation of our own personal computers. I know Alex talked about parallelization of like computers with having 10 computers or 100 computers working at the same time, but I only had one computer. So that was definitely a challenge. And one thing that I found that is, since LSTM is such a sophisticated algorithm, it really requires enough RAM and CPU in order to have enough data accessing and processing speed. So alternatively, we kind of need to write our codes in a more efficient way so that our computer can handle it. And in terms of really the overall challenge of this research, we originally asked for 9 years of data. However, we could only get 8 years just because of the evolving implementation of the EHR at the hospital, as well as we saw the data quality issues that really posed a challenge in ensuring continuity of the data set. Another challenge was that we could have used more refined and detailed timestamps, such as, for example, order entry of interventions and the timestamps of those, but those data elements may not actually be available or even easily accessible from the EHR system at the time when we're doing the study. And lastly is, again, the limited processing power of my own computer, which or even just the way how I could have written the codes, which kind of prevented me to explore, so for example, automated feature selection processes to select the most relevant independent variables, or performing grid search of optimal model hyperparameters to improve model accuracy. So I just want to quickly show you guys my research results. So for the results in experiment 1, this graph shows the average test loss values across the different models. So the best LSTM model was achieved by the LSTM RNN using MSE with a 4.49 minutes of prediction error in ED wait time. The simple NN model with MAE and the LR model with MSE, they both achieved better than their counterparts. So when we were comparing these with the best LSTM model, actually neither comparisons were able to reject the null hypothesis to support that LSTM performed significantly better. So, but in this experiment, the use of MSE, as we can see, consistently resulted in lower range of prediction errors as opposed to using MAE. And in terms of processing time, the linear regression took 18 seconds, while the simple neural network model took 2 weeks. So this is again highlighting that processing power of limitation. And for the second experiment, this graph shows the average test loss values across the different models for the 5 CTAS level wait time prediction. So since the use of MSE, so the red and the green columns produce the lowest prediction error across CTAS levels, when comparing these models across each CTAS level, we found that again, none of the comparisons were also able to reject the null hypothesis. In terms of the processing time, very similar. LR, or linear regression, took 20 seconds. However, the LSTM models here took about 9 hours. So still a great difference between the simple and the very sophisticated model. And I just want to now go into sort of the future and research contribution part. So this project really, I think it contributed to academic research in healthcare management, particularly in academic research. It was the first study to apply sort of this complex model or method to predict ED wait time, and really to explore the temporal relationships between different patient timestamps across the patient hospital journey from arrival to discharge. It provided an example that it is feasible to use typical data elements collected from the EHR in a very complex machine learning method. And this project also contributed to healthcare management in that it really offered a new avenue of addressing a complex systemic healthcare issues. And particularly, it really has the potential to sort of enable providers to make proactive decisions and inform health policies, particularly with this clinical decision support tool, as well as provide patient autonomy and informed decision making. And I think this research opens up future possible other researches. So the technical aspect, as we kind of mentioned, we can explore many different other types of machine learning techniques, or even just looking at feature selection, grid search, or playing around with various lengths of multi-patient sequences. Those could potentially enhance model complexity or prediction accuracy. And in terms of the practical aspect, we would really want to think about how can we make a real-time model feasible in the integration of the health information system. So there are a few elements to consider here. The first one is a model learning from the currently available yet incomplete patient hospital journeys can make a real-time model more desirable in the integration. So basically, how can we utilize timestamp data of patients who are still being cared for at various stages of the ED or in inpatient unit to train the model that is more feasible in real-time prediction of ED wait time. And so due to the complexity of the LSTM model, it is known to have a high computational cost. So how can we optimize it? How can we optimize the training time? And should we consider another simpler model that is able to provide the same qualities, such as, for example, gated recurrent unit, GRU, which is a simpler version of the LSTM model? And three, since patient population health needs evolve over time, just like the pandemic, our data set also shifts, in which it will affect how the model performs over time, needing a retraining of the model. So how often and when should we retrain the model, and how can we monitor this? I want to just encourage you to kind of take a look at this article by Kelly in 2019. It really lays out the challenges of incorporating machine learning to the clinical front. It really bridges the technical aspects of AI via the clinical lens that's relevant to us. So, and it raises really interesting issues for us to consider that, when we're implementing machine learning models, what are the things that we need to sort of think about? So I highly recommend you to take a read. And so in conclusion, ED overcrowding is, this problem is a multifaceted and systemic problem, which can be proactively addressed through various machine learning means, such as the ED wait time prediction. And I think this project, it is a novel research where it utilizes LSTM, as well as sort of based on the theory of the statistical learning theory. So we weren't able to show LSTM perform better, but I think the findings really demonstrated application of the LSTM model in the ED wait time prediction problem and highlighted different model qualities regardless of their complexities. And future work for sure, definitely looking at how can we improve this model performance, or how can we implement a real-time prediction model that it's usable and it's feasible in enhancing patient care in this ED overcrowding problem. And so this is the end of my presentation. I will hand it off back to Alex.
The future research direction for big data analytics or data mining, here I give you some important directions. You guys, if you want to pursue graduate study, probably those thoughts can be useful for you. As I mentioned earlier, big data are not usable until they can be aggregated and integrated into a manner that computer can process to generate knowledge. However, given the wide range of data location, formats, structure, and access policies, the data aggregation are very complex. For example, a healthcare researcher was interested in knowing how the gene myosin light chain 2 was associated with chamber type hypertrophic cardiomyopathy, apologize for my pronunciation, and the similarity related to a subset of the gene's features and the potential connections between pairs of genes. Those three study questions are the question the researcher want to know. But the problem is, where do I find the data this researcher need to do the analysis? Okay, and how to retrieve data from well-known databases such as NCBI, Gene, and PubMed. And if there's other possible data resource available for use for this research. Okay, and can we use a single search engine to obtain all relevant information drawn from a variety of data sources and are expected to act as a whole. To achieve this objective, we need a mechanism to help us while describing a digital source that allow it to be understood by both human and machine. So this is the question. So we need a metadata mechanism to help us, just like use metadata to find the health data for the study question, just like Google search. You provide a keyword, and then use the keyword, the mechanism can help you to go to the healthcare authority data to give you the data you need. However, metadata integration has several challenges, as I mentioned earlier. Here, this is the example I already shown to you. So the challenges. Hold on, I need to jump to here. Okay, as I already demoed to you in the previous slide. Okay, here. Okay, say hospital X use, come on. Hospital use sex to describe patient's gender, and hospital Y use actual term gender. And as I described earlier, some use birthday to describe patient's birthday, and some use DOB, some use diagnosis, some use symptom. Those kind of the issue is the main issue that you want to integrate data to be the uniform for the analysis, just like Charlie demo earlier. And this kind of the challenge, we call it metadata integration challenge. Okay, and this is the actual example to show you why this is the issue. Look here. Can anyone tell me how many female patients with knee injury in hospital A, B, and C in total? Can anyone answer me this question? So this is actual or example question for your future study, because you need to aggregate data from different locations, different hospitals, different data repositories with a different structure of using metadata. Can anyone tell me this question? This is a very simple question. I can take a few seconds to check this. Diron, can you answer me this, Diron?
Yeah.
How many?
I don't know.
This is an interesting
Maybe
example.
2.
Yeah,
I know
okay.
I work with you for quite a few years now, so I kind of know where you're going, but yeah.
I don't want to challenge you, but just give you an idea, you guys an idea, because sometimes I think, oh, this is pretty straightforward, but actually, this is a big challenge. Even here, it's only 3 data sets from different locations, hospital A, B, and C, just a few records, but it's still a big challenge, right? Now, look at here. Hospital A has 2 female in the database, and only 1 female get the knee injury, and the code is using ICD code. And hospital B, you can find there's a 2 knee injury, but only Sudu it's female. And hospital C, gender is used 0 and 1. Okay, and the symptom is used as a snowman CT. Okay. So if there's 3 patients who is a female and got knee injury. And this simple example to give you an idea, right? How to integrate the metadata is a big issue. Okay. So standardized big data annotation. It's the research direction. In the past decade, many metadata standards, such as the doubling core, METS, IEEE, LOM, ISO 11179, and EDA or Mark 21 have been developed by a variety of community to address this need. So try to standardize the metadata. Okay, even data itself, you need to use metadata to describe the data. And the metadata, different organizations use different terms because the metadata itself is a data, right? And different people use different terms as the metadata to describe the data. And how to integrate or standardize the metadata is a big issue because the different organizations develop their own metadata standards. Okay, this is a typical example. When I was at Stanford, I used this example to demo why this is important. That different metadata standards serve distinct needs and communities, and each standard defines its own vocabulary and syntax. Okay, for example, in the table 1, doubling core, okay, used in Stanford library to describe a book's information, and doubling core to describe books title is used title, and EDA used in the Congress, US Congress library is title proper, and in the Berkeley University library use Mark 21. Okay, and how can you expect computer know to that title equal to this or creator equal to author? You need to predefine, but different organizations use their own metadata to describe data. So metadata integration is the big issue. If you have a chance to go to Francis' course, healthcare standards course, I think you can learn more about this kind of the issues, metadata integration in the healthcare. Okay. And to answer this question, I give you an example. When I was a visiting professor at Stanford, I was involved in a project called CEDAR. And CEDAR was a funded Center of Excellence supported by the US NIH Big Data to Knowledge, short of the BD2K initiative. And this initiative is a $647 million US dollars project. And CEDAR is a part of the project. And probably is a 25 million USA dollar project. I was involved in this. And the purpose of this project was to create a unified framework that researchers in all scientific disciplines can use to create consistent, easy, searchable metadata. What does this mean? This means Stanford CEDAR project want to develop a Google similar interface so that the healthcare researcher key in a keyword, say breast cancer, and then this breast cancer will send out to different healthcare laboratory, repository, or database and extract all the data, come back to visible or accessible to the researcher. But actually, the back end or background data is in different locations, different geographic locations, different authorities. Okay, so this is objective of CEDAR. And the key technology or method need for CEDAR is that need to integrate the metadata because, as I said earlier, different healthcare repositories use different metadata to describe the data. So the keyword, say breast cancer, and you need to know, okay, this is disease, and other repositories probably use SYX or something. Okay, so this interface need to have this kind of ability to integrate the metadata to know, okay, this data belong to the data that the researcher need. Okay, and then go to second research direction is called parallelization of computing model, as I introduced you, because the big data in healthcare is very heterogeneous and distributed and different access authority. So if you are able to integrate them together, and then you need to apply a specific algorithm or proper algorithm to analyze the integrated data. Okay, so you need to have a certain kind of the platform and algorithm that you are able to use a limit of time, okay, to get the pattern you need in the integrated data set. Okay, but some algorithm, it's not easy to parallelize it. Okay, particularly for computationally intense problem, the data mining task can be distributed over many computers to reduce computing time. And then you need to have a algorithm that can be parallelized to distribute to each single computer to calculate the pattern or information, and then finally integrate it together and to give you the final result. Okay. So we need to develop some kind of the distributed data mining algorithm. And this is the directions because nowadays exist algorithm can be used for ordinary or some data mining data set, but if we want to apply the algorithm to the big data set, okay, probably it's not possible to get the pattern or result in feasible time. And the third research direction is that pattern visualization. As I mentioned in early slide, BDA is of little value if decision makers do not understand the patterns it discovers. Unfortunately, given the complex nature of data analytics in big data, it is challenging to represent and interpret the result in a form that is comprehensible to non-experts. Therefore, using diagram to help healthcare professionals to easily understand the pattern or trend is very important. Nowadays, Tableau, those kind of the software, it's very popular. So, but if you develop your own big data analytics project, probably exist or off-the-shelf software, it's not feasible. So you need to develop your own pattern visualization tool or software. And research direction 4 is data privacy protection. Because the data security and privacy are major barrier for big data analytic implementation. And existing data privacy protection study can be categorized into two main approaches. Okay, this approach is called privacy by regulation. And the second category is called privacy by technique. The privacy by regulation is that it assumes that policies and regulations are generally enforceable to protect users' data from accidental disclosure or misuse and facilitating from the choice options. For example, the Health Insurance Portability and Accountability Act is called required, we call it HIPAA. This regulation rule as I mentioned earlier, it required to remove of 18 type of identifier, including any information that could identify individual patients. And these privacy mandates are a major barrier for big data analytics in implementation. Okay, and the second method to protect data privacy and security is called privacy by technique. Research in this field aimed at developing privacy method and system with provable privacy guarantees. For example, data masking, encryption, access control, etc. Okay, probably some of you want to know what is the data masking. Here is the example. Okay. Okay, I'll give you an example here. Okay, so this is the original data set in the BCMOH I conducted a few years ago with a professor in nursing at UVic. Okay, so we want to know how many male patients aged less than 40 have a knee injury in Victoria. If you have a data set like this, okay, of course, this is the original data set. You have, come on. My mouse has a problem. Go back. Come on. Okay, so this is the full data set. Of course, the data itself is made up. All right. And because the regulation BCMOH remove the patient's information, include patient genders and address, name and address. And then the study question is, how many male patients aged less than 40 have knee injury in Victoria? Can you tell me this? Guys, can any smart student answer me this question? If you design an algorithm to answer, no, you are not able to, because you lost information to connect informations and to get the pattern you need, right? Because the privacy issue, the data holder, data set holder, remove some key important information. For example, gender or address, right? Because this data set lost the address information. You are not able to find if this patient, okay, this patient is in Victoria or Vancouver. Okay, and now if you have this information, you are able to answer this question. Okay, so this is called privacy by techniques. We can use this method to protect the privacy, but the issue is that you need to carefully determine which data you want to remove or to do the masking. Okay, we still have 10 minutes. Okay, and this is an example, real example. This guy is also a colleague of mine when I was at Stanford. He studied, he published a research in study result in Nature, demonstrate the ability to use non-DNA based information to infer a DNA-based barcode that is sufficiently specified to resolve an individual's identity. Okay, so this is very dangerous. Even you use a technique to block the data, you still a smart researcher or people hackers still be able to use other data set data to identify your information. So this is real. Okay, so new approaches to protect individual privacy in the era of big data has become very important because the big data provide information. Probably your data, say, your data in some kind of say vaccine database system and some data in your car insurance data set and use those two databases, you still be able to connect them together to identify you and your information. Okay, so this is the research direction. Okay, here I'd like to conclude our presentation. Today, a variety of modern health information systems such as EHR, CPOE, PACS, CTAS, and lab system have generated an unimaginably huge volume of health data. We call it health big data. And health managers and experts believe that with the data, researchers can easily reveal important information to better health policy, improve patient treatments, and eliminate redundancy and unnecessary cost. So BDA is the process of extracting knowledge from big data sets in health. It can be considered as a processing pipeline. I already introduced you that involve multiple distinct stages, including data aggregation, maintenance, integration, analysis, interpretation, and each stage faces several specific challenges. I already introduced you in previous slide and provide you some potential solutions. Due to the broad nature of this presentation topic, the primary thought is that it's on discussion the attributes of big data in healthcare, real-world use case, and the challenges and potential solution for health big data analytics. I do not focus on describing the details of any particular technique or solution to a specific data set or application scenario or study question. However, our thought here is that this presentation will contribute to your big data knowledge and advancing BDA research in healthcare in the near future. Okay, thank you very much for your attention. And here I provide you some references. Okay, and you can use a hyperlink to find the paper and see the details. And of course, if you want to know more and do some kind of advanced study, here I provide you some big data education websites, such as the IBM Big Data University. It's online. BD2K, School of Computing Science, Simon Fraser has a dedicated graduate study program for big data, and St. John's, and some innovation hubs. Okay, so any questions? So you can ask me and Cherry any question you have.